Hey, everybody. Devin here with the Heartbeat Debrief, and welcome back. For those of you that are new here, this is the place for the things that don't make it into our charts. The doubts, the dark humor, and the weight that we carry with us long after our shift is over. And honestly, I had a very different topic in mind for today's episode, but on my way home from work today, hence why I'm still in my scrubs, I had a thought, and it's because of an experience that was shared with me after I was done teaching today. So I want to share that with you guys before we kind of get into today's episode. So I have just finished teaching an NRP class with one of my really good friends, and it was a great class. We had a really good time. There were lots of good questions. And afterwards, on my way home, I just received this message from the lead NRP instructor who had received the message from one of the students in the class. It says, "Good morning. I was in the NRP class this morning, and it was the best class that I've had in my 25 years of nursing. There was no stress, just encouragement. I've now taken NRP 12 times, and I left today actually learning something. I'm not the type of person that retains stuff when I'm stressed, and the male nurse, Devin, said before our mock code that you all bring something to the table. You all have something that's needed in a code. And honestly, I have never been told that before, and he was right. We each did what we were good at, and we rocked that mock code." As an instructor, that makes me feel really, really warm and fuzzy on the inside, and it makes me feel like I'm doing my job. As somebody who's passionate about education, that makes me feel just very ecstatic that a student has this feedback about a class that I taught. But it got me thinking, why doesn't all healthcare education environments feel this way? Why don't we, as educators, as preceptors, as training officers, why don't we foster this environment that is welcoming and relaxed? So that's what I want to talk about today. I want to talk about the system that demands competence but won't train it. So with that being said, let's get into it.
The views and opinions expressed in Heartbeat Debrief are solely those of the host and guests. They do not represent the views of any employer or organization. This podcast is for educational, mentorship, and guidance purposes only. If protocols or policies are discussed, always follow your local or state organizational policies and procedures, regulatory guidelines, and scope of practice.
So if we take the NRP class as an example, right? It's a simulation class. It's a certification course. As an instructor, I've taught ACLS, BLS, NRP, PALS. I've taught paramedic programs. NRP is probably the most fun and exciting certification course to teach, in my opinion. And it's because of the way that NRP has set up their course and the way that they do their simulation. It's not like ACLS or PALS or BLS. Those are, I'm not going to say anything. But you have students come into these certification courses and they've got anxiety and they're worried that, they're going to do something wrong and they're going to perform incorrectly and they're going to fail their certification because they mess up in simulation. That's wrong. We as instructors have fostered that creation of that environment for so many years, and we need to change that. We need to get rid of the panic and the anxiety that comes with attending a certification course. I feel like there's a couple different perspectives here that you could kind of go with. You have the student perspective. I've been an EMT student, I've been a paramedic student, I've been a nursing student. And, as an EMT and paramedic student, those simulations, they always felt like life or death. And I had some instructors that were really, really good about, bringing down that panic and that anxiety in the simulation environment and promoting a good, positive learning environment. And then I also had instructors that I was like, oh God, today's going to be absolutely terrible. I don't know what we're doing, but I know that instructor fosters an environment of every patient dies. You did everything wrong. Why didn't you save them? Okay, that doesn't really work. Um, yes, patients die. You can do absolutely everything correct and patients still die. So if that's the learning objective, then that's great. But if every single simulation your patient dies, you're not teaching your students actually anything. But those two environments are very different, right? You have one that's fostering an environment that's welcoming questions, who's wanting the students to learn. Who's like, okay, why are you giving this medication? How much of this medication you give? What are the contraindications? What are the indications? What are the side effects that you're going to give? Did you do your patient education? That is the environment that we should strive for in education and these learning environments. Then you go to, say, like a nursing student. See, nursing students, I feel like, have very, very different experiences with simulation. I went through nursing school during COVID. My first semester, I did my assessment 101 on a pillow. Yep. I definitely heard the lub dub during my cardiac assessment, and I heard equal clear breath sounds. Totally. Okay, I get it. It was COVID. We did the best we could. But then halfway through nursing school, we were allowed to go back and in person. Um, and I don't think I had a single simulation where me and my classmates weren't worried or we weren't anxious about going into simulation because we knew that we were going to just get hammered with something and we weren't going to actually learn anything. Okay. The nursing school instructors didn't foster an environment of actual learning. Okay. They gave us the learning objectives. Fantastic. Thank you. I appreciate that. But then I went into the room and, I tried to do my assessment. I tried to give medication. I tried to pick up the phone and give an S bar. And I was met with resistance from the instructor on the other side of the glass every step of the way. And not in like a teachable way, just a negative, oh, your patient is now hypotensive. Okay, well, I didn't even do anything. Okay, I haven't even done my assessment yet. So, can I please get some more information? Oh, your patient's not breathing. Okay, great. So now I need to run a code. And then it turns into a code situation, and then the patient dies. Why? Why is it always you do something wrong or you don't do something fast enough that the patient dies? As an educator, I can see that if that's your learning point, if that's your teaching objective. Okay. But if your goal is for them to do an assessment, then you need to allow them time to do the assessment. So I feel like, I see from both, being EMT, paramedic, and nurse, my simulation experiences have been very, very different across the board. And then as a paramedic educator, the college that I taught at, yes, we did didactic and we did PowerPoints. However, inside of those classrooms and inside of the didactic lessons were scenario based simulations. And they work together as a team. And I think that's really important because you're never alone, right? You are never alone on the streets. You're never alone in the hospital. You're never alone. There's always somebody with you. And so by involving these students to work in pairs or groups of three inside of a didactic lesson with a simulation, now you've talked about a topic and now your students are acting on that topic and they're taking the time to learn and they're struggling. And I think that's really important. You should allow your students to struggle and learn, and then you can talk about it and debrief about it. You know, the majority of students don't learn death by PowerPoint. Okay. Hands on practical application, in addition to didactic, is where you're going to get the bang for your buck. Healthcare is a very hands on field. If we just do things by the book and teach things about the book and we don't actually do hands on application, we're going to create very, very bad providers and clinicians. And we don't want that. I've found that there's added value in, doing the PowerPoint, yes, discussing it, yes, but then adding in a scenario. And then what you're doing is now your students have the opportunity to take everything they've just learned, everything they've just discussed, and now apply it. They can assess the patient. They can decide what matters first, task prioritization, communication, performing skills, and then reassessing and adjusting. Okay. And then you, as the instructor, can stop and start the scenario as we go and ask probing questions. Be like, hey, I love where you're headed with this, but are you missing anything? Don't give them the answer, but make their brain turn. Okay. Or if they look at you for a help, like they've got a question about something and you don't want to give it to them because they are in the middle of the scenario, be like, is there anybody else that you could ask? Oh yeah, I have a team of people here. Exactly. Use your resources. You can always phone a friend. Okay. And then keep that scenario going. There is no there's no nothing out there that says the scenario has to go from start to finish with no pauses. There's not. And I would say the majority of us out there probably do run scenarios start to finish without stopping. I typically don't stop a scenario unless someone's going to do something that is majorly going to distract from the learning objective. And so I get them back on track. Or if I can take their mistake and turn it into a teachable moment while maintaining my teaching objective, then I may keep the scenario going. Okay. But the majority of instructors out there that kill patients just to kill patients in simulation, you're doing a disservice to your students. And I say that because simulation is where mistakes should and can happen. Okay. I would rather you come into a simulation with me and give somebody 500 of ketamine and learn what happens to that patient with 500 of ketamine in a simulation than go out on the streets and give somebody 500 of ketamine that doesn't need it or is the wrong dose or the incorrect medication, whatever the situation is, right? I would rather you make that mistake with me in the classroom so you can learn from it in a controlled environment and we can discuss about it than out in the real world and have extreme negative effects. Okay. And with those mistakes, because everybody makes mistakes, right? With those mistakes in simulation, your student should never leave the classroom feeling like I'm stupid, right? You as the instructor and the mentor, you should never ever make your students feel like they're stupid. If you make your students feel like they are stupid or they're dumb or they're insignificant or they'll never be a good provider, you probably shouldn't be a teacher. Just saying. Okay. You are supposed to foster these environments, these positive learning environments. You're supposed to welcome the questions. There's no dumb questions in medical practice. I know some people will probably disagree with me, but if you are asking questions, that means you want to learn. If you want to learn, then you are in the correct career field. Never, never make your students feel dumb. Okay. Sure. Make it a teachable moment so that they don't forget, but don't make them feel dumb and don't belittle them. That doesn't do anything for their psyche. It doesn't help them. It doesn't make them a stronger provider. Okay. Give them the education, expand their knowledge, grow them as a provider. You owe them that if you are their educator. Okay. They should leave your classroom thinking, all right, now I understand what I need to work on or what I need to do better. Or, ooh, I will not make that mistake again. Okay. Now, as we kind of transition from, the learning environment, the simulation environment, we transition that into real time practice. Your students are going to carry their simulation experience into clinicals, right? So, yes, we want to make the simulations as real as possible, but that's hard to do in the simulation world, especially if you have low fidelity. If you don't have high fidelity, excuse me, low fidelity is really, really difficult to work with and make real life simulations real. So, you you have to preface your simulations with, the disclaimer so your students don't go out into the real world and expect the real world to be like this simulation. You let them know that we've tried to make this as real as possible. It will give you real-time answers. You will get vital signs from your monitor. You can speak to this person over here or me as your patient. Um, make it as real as possible. Okay. They are going to take that and they'll be like, okay, I did this in simulation. I know that was a mannequin, but I did all of my steps, right? I did my ABCs. I got my vital signs. I treated the patient appropriately. I did all of those things. They can take that and they can apply it to this real world patient now. If you just have your student trying to interview a mannequin that doesn't talk to you and be like, "Hey, go forth and conquer. You've passed your health assessment class. Go start interviewing patients." But you never once took the time to be that patient for them to actually interview, so they don't actually know how to talk to patients. They're going to take that with them. Okay? Just remember that. You have to make it as real as possible for them. With that, if your students were mocked or made fun of for asking questions in school, they're probably not going to ask them during orientation or in clinical situations. Probably not going to happen. If you made them feel ashamed of the mistake that they made, they're probably going to hide a mistake. That's fostering a terrible culture, okay? They need to be forthcoming with their mistakes. Yeah, we have to improve this culture of hiding mistakes because hiding mistakes is how people get killed. Last time I checked, we're all in the business of keeping people alive. Just overall, like we have to build confidence, okay? Confidence in a judgment-free zone. And there's confidence and competence, and then there's exams and memorization. Very different things here, okay? I can teach you how to pass a test. I absolutely can. I can teach you values to memorize and vital signs that are normal and vital signs that are irregular and contraindications for medications and indications for I can teach you those things and you can memorize them. Great. But if you cannot regurgitate it back to me with the why behind it, okay, you are not competent and you are not confident. Okay. I had a paramedic instructor tell me one time that he doesn't make cookbook medics. Cookbook, textbook, however you want to look at that. But he doesn't make cookbook medics. He makes critical thinking medics. And so he would teach us something, but then we would have to do our own due diligence and go back and learn more about it and the why, the how, the what. And then we'd have to go back to him the next day and be like, hey, you told me about XYZ? Well, here's ABC to go with that. Okay. And it shows that you have that critical thinking and that critical understanding of whether it be the disease process, the pharmacokinetics, the pathophysiology, anything, whatever that topic was. Okay. That is how you develop your students, not just memorize, test, pass the exam. Okay. And switching gears a little, we're going into the hospital side of things now. And you see, you have residency programs and new grad programs. Um, but what you're seeing a lot of and a lack thereof is unit educators and the lack of education that the unit educators are providing. Okay. I've worked for a number of hospital systems, and it always seems to be that the educators are focused on new hires, making sure that all of their competencies are signed off, and then annual competencies for staff. Great. And it's checkboxes in health streams, it's checkboxes in ULearns, it's wherever that your hospital-based education is. Checkbox. And then your educator is going through and making sure that everyone's doing those. Great. Fantastic. I think everybody should be competent in their skills. Yes. However, I think that our hospital systems are doing us a disservice with our unit-based educators because they're not providing continuing education to our staff. They roll out updates from the hospital, from the hospital corporation, whatever, but they're not taking the time and going around and talking with people and going through like policies, procedures. They're not hosting skills days. They're not actually educating the nursing staff. There's no education happening. If there's new clinical practice, evidence-based medicine happening out there and our providers are interested in it, our providers should be able to give that to the educator, and the educator should be going around and talking about it. Be like, hey, this is what we're going to start doing. This is the education behind it. This is the evidence behind it. Okay, you can't just throw something into an email and send it out to everybody. That's not helpful to anybody. And so I feel like our hospitals are doing us a disservice with our educators. And, with that in mind, orientation and precepting also goes hand in hand with that. Your preceptors are already doing the boots on the ground, hands on teaching at the bedside. My orientation was 10 weeks with a preceptor, 10 weeks on my own, 10 weeks with a preceptor. Okay. Each time with a preceptor, different levels of acuity, different skills to be learned and to be taught. So 30 weeks, give or take, in orientation. In that 30 weeks, there are still things that I did not get to see. So my preceptor and I, we just talked about it. Okay, well, if the preceptor can't get me the assignment that gets me this education and gets me this learning, then it should be the educator's role to set up a simulation for me to get that experience and learn how to take care of those patients. But that's just my 2 cents. There's also when we roll out new equipment, or I already said policies, rare procedures, skills, hospitals and the hospital educators should be required to make sure that people are trained on those properly. We got a new feeding pump at work. And yes, I received my 1-hour health stream class on how to operate this feeding pump. Sure did. I sat through it. I read the PowerPoint. I read the handout. I clicked the acknowledge button. I know how to operate it. I sure do. Guess how many people don't learn just by reading? I don't know, but I'm one of them. And so I didn't actually learn how to use this feeding pump until probably 2 months after the pumps had been rolled out because I had not taken care of a patient with one. And then I finally got my hands on one and I was able to learn about it and see how the tubing fit and everything and the buttons. And those things should be made available to staff well prior to them being rolled out. I shouldn't have to walk into a room and be like, I don't know what that piece of equipment is. How do I use it? That's dangerous. That's not fair to the patient. That's not fair to the staff member. That's It's literally dangerous. So, as an educator, if you know that your floor is getting a new piece of equipment, it's your duty to make sure that people get the hands-on time that they deserve. And do you know who probably suffers the most when new policies, procedures, and equipment get rolled out? Who don't get like face-to-face or hands-on training? Night shift. Why? Because hospital corporations want to make a training at 2 o'clock in the afternoon. I'm sorry. Do you want me to host a training for you on day shift at 2 o'clock in the morning? No, I bet you probably don't. So why is your only opportunity for a night shift training 2 o'clock in the afternoon? That's how we get so many providers who don't feel competent or confident when things change. We have a lack of education. Night shift suffers the most. You cannot demand competence while refusing to provide opportunities to maintain said competence. And in order to maintain that, you need money. I understand that. Do you know who has lots of money? Hospital corporations. Hospital corporations have lots of money. They just don't want to put it where it matters. Okay. On the flip side, private ambulance companies, they don't get a lot of money. So, how are they supposed to provide all of these continuing trainings and keep their paramedic skills and their EMT skills up to date if they don't have money? Hey, that's another problem. Because I am a firm believer that paramedics, we do not get enough intubations in the field. It is statistically proven there are not enough intubations in the field for you to maintain proficiency in intubation. Okay. That is a proven statistic. But in order to combat that, organizations throughout the nation have taken, the extra step and have been able to get, big fire departments, critical care transport. They're able to get their clinicians into like hospital ORs to get intubations so that they maintain that proficiency. Okay, the majority of private ambulance companies cannot do that. They can't fund that. So there's lack of resources, okay? Lack of funding. So what do? They do the plastic mannequins. Not great, but it is practice, okay? It is practice. So there's a lack of funding throughout healthcare for continuing education and maintaining skills. you know, more and more of like cadaver labs or airway labs. They're popping up all over the country. And I think that's phenomenal. And every organization out there that is doing that and is pushing for that, keep up the good work. Please, please, please. Because I have learned so much from the few cadaver labs that I've been able to go to. And it's it's eye-opening for a lot of these providers because they haven't done some of these skills before. They work on an IFT truck. They don't work 911. And so they don't get to use these skills. Technically, they are a paramedic. They can perform these skills. But if they don't do them often, they don't going to feel confident in them. Okay. So we need to be able to make access to cadaver labs, airway labs, advanced simulation trainings, conferences. There needs to be more access to these things for people to go to them. Okay. We have to. So, what I think that healthcare systems as a whole, whether you be a fire department, a transport agency, a 911 agency, a hospital system, you should be providing educators who are invested in your team and the education that your team is receiving. Okay? There should also be protected time for education. I should be able to take, an hour a day and learn something from somebody or structured field training programs. A lot of organizations are doing really, really good work with their FTO programs, but then there are other organizations out there that could use some help. So if you are one of those organizations that you feel like that your FTO program is struggling and it needs some help, find a program out there that is thriving and people are happy to work at and have nothing but good things to say about them. Reach out to them and ask them, be like, hey, what does your FTO program look like? What do you guys do in addition to, just your field rides? Do you require your FTOs to go to weekly classes, and do you do skills labs, and do you have them do scenarios with the education team or the medical director, or what does that look like? How can we make our FTO program more robust? Okay. Healthcare system should also be funding certifications, conferences, and skills labs. There is enough money floating around out there. If you don't want to give people raises, fine. At least give them money to go take certification tests or pay them extra for their certifications after they've got it. Give them a differential. Give them a $2 differential for their certification if they have one. Okay. Or give them a bonus every year if they have a certification. Okay. Some places do that. I think that's fantastic. And then give people like a reimbursement. Be like, hey, you get $500 a year in education credit. You could use that however you want. Okay, well, $500 for an education credit, that's not going to quite buy my trip to a conference that I want to go to, but that'll help me get there so I can attend this 3-day conference on a topic that I'm interested in. And then I can get reimbursed $500. Okay, we should be making access to education way more available. And then just simulation environments where questions and mistakes are expected and questions are welcomed, and we're fostering good learning environments. All right. I think you guys have probably heard enough of me rant for today. I really feel strongly about education, and when you can get students that share with you that it is the best class that they've took, or they felt like it was a welcoming environment. They weren't anxious. They weren't scared. They felt like they could make mistakes. That's just so nice to hear, because now you know that they're going to go out into the world. They're going to be a more comfortable provider. They're going to be more competent, and they're not afraid. Okay? They asked the questions in simulations. They learned something. They're not going to make that mistake. So I will leave you with this. If we expect nurses, paramedics, firefighters, and every other healthcare professional to perform when the stakes are life and death, then we need to give them real opportunities to learn, to practice, to fail safely, and get better before a real patient is depending on them. So until next time, take care of your patients, take care of yourself, because you never really clock out.